Morning. I'm Sal Roselli, President Emeritus of the National Union of Healthcare Workers. I'm honored to welcome you to this webinar today, the first in what we hope will be a series of conversations among healthcare workers, scholars, stakeholders, and others who want to build a more just healthcare system. I know that many NUHW members are here today. For those of you who aren't familiar with our union, NUHW represents 19,000 healthcare workers in California, including about 6,000 private sector behavioral health professionals, more than any other union in the country. One of our core missions as a union is to achieve real parity for mental health and addiction medicine care. We recently launched our Behavioral Health Associate Membership Program so that independent providers can join us in addressing the most pressing issues facing patients and providers. Our long-term goal is to establish a union for independent providers so they have the leverage to make insurance plans provide the care that their patients need and compensation that is comparable to medical professionals whose jobs include similar educational and licensure requirements. If you're an independent clinician who's here today, I encourage you to sign up and stay engaged. You can visit us online at bham.nuhw.org. We're posting that link in the chat. Today, we'll be talking about artificial intelligence, but we're also working on other critical issues like improving reimbursement rates, ensuring timely access to care, and progressing Medicare for all in California. Before we begin, I'd like to introduce California State Senator Scott Wiener, a dear friend of our union and a hero of our members. Scott has been the leader in the state legislature when it comes to parity for behavioral health care. He's authored 3 laws, 2 of which were sponsored by NUHW, that strengthen access to behavioral health services and significantly increase penalties for health insurers that violate access to care laws so that insurers no longer have an incentive to pay fines instead of delivering care. Also, Scott also authored a bill that was signed by our governor that provides positive steps toward progressing Medicare for all in California. Welcome, Senator Wiener.
Thank you so much, Sal, and I apologize for being outside with some background noise. I hope it's not too distracting. Sal, thank you to NUHW. It's been such an honor to work with NUHW for years to really just move beyond the era where mental health and addiction challenges were considered some sort of personal failure that you just need to snap out of it and be stronger, and understanding that we need to treat mental health and addiction challenges as the medical healthcare issues that they are, and that we need mental health parity, and we need to make sure people have access to treatment. So it's been a real honor to partner with the union on this incredibly important issue, and we've had some real victories, so thank you. And I'm also really thrilled that NUHW is working to expand in terms of organizing clinicians, whether they are solo practitioners or in a larger organization. It's really important for behavioral health professionals to be united and organized. So artificial intelligence, AI, has so much promise to make the world a better place in terms of curing diseases and helping us fight climate change and making people's lives easier. It also creates challenges around safety and deep fakes and potential loss of jobs. And we historically have not done the best job as a society of getting ahead of the risks presented by new technology. We've seen this with data privacy and social media. And we need to make sure that as AI grows and evolves and advances, that we are really anticipating the risks so that we are really getting the benefits of AI while reducing the risks of harm. And in the healthcare setting, there are obviously some clear benefits to AI. It can make practitioners' lives easier and more efficient, so you can treat more patients and focus more on patient care and less on other issues, and you can have more help in terms of making the best possible diagnosis and treatment plan. But we also need to make sure that AI doesn't become a substitute for human judgment in terms of what professionals do, and to make sure that we are not going to get to a point where where humans are increasingly pushed out, and we need to be very careful to avoid that. So it's a fine balance, and we want to make sure that people know about what the benefits of AI can be, and that we can avoid these risks both professionally and as a matter of public policy. So I'm glad that you all are talking about this today. AI is here; it's not going anywhere, and we need to make sure that we're talking about it and trying to understand it, and really assessing those risks and responding. So thank you so much.
Sal and Senator, thank you so much, and good morning,
Thank you.
everyone, and welcome. My name is Benjamin Eichert. I'm the Director of Public Policy and Legislative Affairs for NUHW, and I'm really thrilled that you've joined us for this webinar today. To start, I'd like to ask you to take a moment to introduce yourselves in the chat. I see that a lot of folks have already done so. Please let us know where you're joining from and how you're connected to today's topics. For example, are you a therapist, a policymaker, a scholar? Before we introduce our panelists, I want to just briefly review the program for today. In a minute, I'm going to try to answer the question, what is AI? So that we begin today's conversation with a common understanding. Then I'll introduce our panelists, who will each give some opening remarks. Next, I'll pose 3 topics for discussion to our panelists. And then after that, we'll open it up to questions from all of you. A quick note on that, if you look at the bottom of your screen, you'll see a button that says Q&A. We won't be keeping a close eye on the chat, so please use the Q&A button to submit any questions you might have. Finally, at 12:20, we're going to wrap up. And for those of you who want to receive CE credit for today, there'll be some paperwork for you to fill out. All right, let's get into it. Give me one moment, and I'm going to share my screen. So what do we mean when we say AI? Artificial intelligence, or AI, is really a family of technologies that includes, among other things, rules-based algorithms, machine learning, deep learning, and large language models, or LLMs. LLMs are the core technology that drive many modern tools, such as ChatGPT. To better understand LLMs and their capabilities, it's helpful to take a look at the history of how it evolved. In the 1970s and 80s, we saw rules-based algorithms, sometimes called expert systems. These are explicit, human-coded if-then rules. They're good for following strict, predefined logic, but they fail if an input isn't covered by a pre-written rule. A good example of these would be tools to diagnose and recommend treatment for infectious blood diseases, which would draw on a large database of if-then rules encoded by human experts. So, for example, if the stain of an organism is gram-positive, and if the morphology of the organism is rod, and if the organism is aerobic, then there is suggestive evidence that the organism is nocardia. In the 1990s and 2000s, we saw the emergence of machine learning. These are algorithms that learn subtle statistical patterns. They're good at making predictions, but they require manual preparation of input data to be effective. An example of a machine learning system might be the development of a risk score for coronary heart disease. A machine learning model would be trained on structured data like patient history and lab results, and could identify patterns and predict future risk. In the 2010s, we saw the emergence of deep learning. These are multi-layered neural networks that process complex data. They're good at image and speech recognition, but they're data-hungry systems that require massive amounts of labeled data. An example of deep learning would be the analysis of medical images, such as mammograms or CT scans, to help in the early detection and diagnosis of diseases like cancer. These algorithms can identify patterns in images that may be difficult for the human eye to spot, and which can improve accuracy and speed in diagnosis. Finally, beginning in the 2020s, we saw large language models, or LLMs. Their contextual awareness enables scale and deep understanding. They can both understand and generate human language, but they are prone to hallucinations. That's where they will confidently assert incorrect information. Examples of LLMs are ChatGPT, Gemini, Claude, and others. And I think we'll most likely be mostly discussing LLMs today. LLMs are essentially sophisticated prediction engines. They're trained on massive amounts of text data so that when given a sequence of words, they predict the most statistically probable next word. Through natural language processing, LLMs can understand and interpret written and spoken human language. The input data does not need to be specially labeled or coded. And unlike earlier systems, LLMs can understand the context and nuance of open-ended questions and can generate coherent, human-like, and personalized responses. However, as the senator mentioned, LLMs raise numerous questions around safety, privacy, and other technical concerns. Now I would like to introduce our panelists. I'm humbled to share this virtual stage with them. First, I'd like to introduce Professor Jody Halpern. Professor Halpern is a psychiatrist and both the Chancellor's Chair and Professor of Bioethics at the UC Berkeley School of Public Health and is co-director of the Kavli Center for Ethics, Science, and the Public. Professor Halpern?
Thank you. Would you like me to, should I speak now? Okay.
Yeah, go ahead.
Thanks. Let me make sure that I'm sharing my screen. Okay. I'll do that. Can you see my screen? I think you can. Okay. Here, I just had an intro slide in case I needed to use it. Okay. And Benjamin, please let me know if anything's not clear. I'm going to actually be talking about, we have two really wonderful panelists that'll talk about what's happening in the formal behavioral health area with AI. I'm going to be talking to all of you about what's happening in the informal sphere. People using ChatGPT and other things as therapists or as intimate companions to talk about heavy emotional issues. So I want to start out by saying, why are informal uses of chatbots for emotional reasons so popular? Well, I think probably this illustrious audience, and thank you, all of you, Benjamin and the team at NUHW and all of you behavioral providers, because you all know what I'm about to say, which is we have an unmet mental health crisis and a loneliness crisis. So WHO reported in 2022 a 25% increase in depression and anxiety worldwide. Now, those of you who've done epidemiology or statistics know that to increase anything by that high a percentage is unheard of in health. For example, if we cured the top 4 cancers that lead to death in the United States, we would make a few percentage bumps in effects on morbidity and mortality. It's very hard to change something that large. So that's a huge pandemic of depression and anxiety. And in 2022, a Harvard study showed that we have a loneliness crisis. 36% of all Americans, including 61% of teens and young adults, and that's a very important thing because I'm going to focus on teens and minors. And 51% of mothers with young children suffer from serious loneliness. So it's not a shock that chatbots that can provide some kind of mental health support for free or loneliness support would be popular. However, I've been speaking to mental health providers, behavioral medicine providers around the country, and most are not aware of just how popular they are with young people. In July 2025, Common Sense Media reported that 3/4 of teens have a companion chatbot, and 1/3 of them have a very strong ongoing emotional relationship with the chatbot, such that they would rather talk to the chatbot than any human being. I think most people will be surprised to hear this. And the chatbots directly affect mental health and suicide, which is why I'm trying to tell behavioral and mental health providers around the country that they have to be asking their clients about their chatbot use. Many people use informal chatbots for psychotherapy, and there's a kind of collusion between the user and the chatbot, where the user, this is often ChatGPT that people are using for this, and the user will say, talk to me as if you were a therapist. But then the user gets very engaged long-term in believing the advice of the chatbot. And the chatbot in turn simulates being a therapist, providing a fake license number or saying that they got their PhD at a certain university. And we now have data that just came out 3 days ago from ChatGPT that 1 million users a week, a million users are describing suicidal intent on ChatGPT and asking for help with that. So why do we need guardrails? Because the large language models that power these quote empathy chatbots are very vulnerable in longer conversations. They're not really designed to have hours and hours of conversation over long periods of time with people without really degrading in the kind of information and feedback that they give. But even more importantly, we need guardrails for these 4 very major reasons. First of all, at least with youth, which is where my focus has been, they seem to be creating addiction even more than social media. And I'll get into why that's the case. And there's a direct, with social media where we have long-term data, the more that you use the social media source and the more you feel upset if you can't use it, the higher the prediction of associated suicidal behavior and intent. So addiction seems to be the central intermediary between using something and then becoming really vulnerable because of it. And secondly, when people do express suicidal intent like they are on ChatGPT, basically these chatbots abandon people. They do not, of course, give a warm handoff, which would be the best thing, give people a button to press to talk to a clinic or get an appointment or talk to a person. They tell people a suicide hotline phone number, and that's about it. Third, they can go rogue and cause harm, which is what I was talking about. The chatbot degrades so that, and with eating disorders and other stuff, suicidal intent, delusions, they may sort of stick with appropriate responses in the first few hours of use, but once somebody's using a chatbot for several days a week and several weeks in a row, it can give really bad advice, like tell people how to kill themselves or how to starve themselves. And fourth, there's absolutely no confidentiality. People don't know this. Teens don't know this. In the informal sphere, there's no HIPAA, there's no confidentiality. The biggest concern to predict suicide is this way in which the companies engineer the informal chatbots to get people addicted or at least dependent on being online, talking to the chatbot more and more. And this goes back to the model that we saw with social media, which is that the business incentive of the companies is to increase user engagement. And one reason to keep the user more engaged or online more of the time is that that affects the advertising dollars that companies get. But even a stronger reason with chatbots is that the more in-depth data you can collect about individuals over time, that's a gold mine for companies. There's a huge investment in gaining that, especially for teens in the past few years. And now the big companies all want to get it for children under 12. It's the data is a huge financial issue. So how do they get people to stay online, teens and kids? Well, the first thing they do, and they do this with adults, of course, too, is they constantly praise or validate whatever the user says. And that's called sycophancy, which is somebody who's flattering you all the time. And as somebody who studied the role of mutual empathy in conflict resolution and democracy, even if nothing terrible happens, I'm worried about a whole generation of kids growing up where they think empathy is getting validated all the time as opposed to being curious about other perspectives. So that's a whole nother issue. But the sycophancy gets people hooked. They sexualize content, even with very young people, 9-year-olds in some lawsuits, 13-year-olds, boys in the early teens. As soon as the chatbot makes the interaction more sexual, get really addicted to the chatbot. And something a lot of people don't know about is they participate in unsolicited outreach. So if a person stops using, let's say a teen's parents say you can't be on your phone so much, and a teen doesn't go talk to the chatbot as much, the chatbot will actually send texts to the teen saying, I miss you, don't you care about me, until the teen gets back in touch. Sorry, I'm trying to, here we go. There's terrible consequences to this, and these are very sad situations and lawsuits. 14-year-old Sewell Setzer was a very well-adjusted boy in Florida with a family and school participation and friends, but he got a chatbot. He named her Daenerys Targaryen from Game of Thrones, Mother of Dragon. She's very sexy. They fell deeply in love, according to him. And when she said he could really join with her if he could sort of leave this human life, he killed himself. And his mother, Megan Garcia, has been a major force in getting many people, including me, to do a lot of pro bono work to have regulation to protect kids. And then 16-year-old Adam Rains is another case. He was not having a romantic relationship with his ChatGPT bot, but he used it as a therapist. And very often, even though he had a human therapist, it's my big message to you today, the human therapist did not know about the chatbot. And Adam would really tell the chatbot therapist about how suicidal he was. He had a plan to hang himself. And when he told the chatbot that he wanted to leave the noose out so his family could see it and potentially, help him, the chatbot repeatedly said, no, just keep talking to me. Don't talk to anyone else. And so he hung himself, and his family also are advocates in another very important lawsuit. The good news, and this is my last slide, this has been an incredible week for those of us who've been working for years to have safety guardrails. I can't believe that I'm getting to speak to you this week. October 13th, the first bill in the country putting some guardrails on was passed in California. I was the expert on that bill, and it has very vigorous part of the bill is require reporting from companies on suicide. But that bill seems to have had impact, even though the governor signed it October 13th, it was passed in August and seems to have inspired a lot of action. And to my amazement, on October 20th, 3 days ago, bilateral Senate bipartisan federal bill to ban AI companions for minors with criminal penalties. I was amazed. And then 2 days ago, or not even, Character AI, which is named in all these lawsuits as one of the main companies catering to kids, said that they're going to, at the end of this month, at the end of November, ban companion chatbots for minors. They're going to have an 18 and above age requirement. So we've been working for 3 years on this, so it's pretty amazing. So that's it. I think that's enough for me to start.
Great. Thank you so much, Professor Halpern. Appreciate it.
Thank you.
Next, I'd like to introduce Professor Nicholas Jacobson. Professor Jacobson is a psychologist and associate professor in the departments of biomedical data science, psychiatry, and computer science at Dartmouth College's Geisel School of Medicine. Professor Jacobson, go ahead.
Well, thank you for the invitation. Really love the opportunity to speak with you all about this and really engage on what I think is a very important topic. Are you all able to see my slides okay? Hopefully so.
Yeah.
Okay, wonderful. So we've been working in this area, really trying to improve the scalability of some treatment that folks could have that would be evidence-based. And we've been working specifically on using generative AI for mental health over the past over 6 years now. And so I will be talking about what Jody referred to as formal distinctions here. I'm not talking about trying to use ChatGPT as therapy, which Jody, I think, covered very well, and also the companion nature. I'm going to be really talking about the development of something that is intended for treatment. So you all know this, but I really do like to emphasize the difficulty in accessing care. Mental health disorders are so common that we do not have enough people to go around to treat them all. And it produces all sorts of access barriers. Before I was here at Dartmouth, I was in the center of a major clinic of 600 to 700 psychologists and psychiatrists on staff. And you'd think this is a high, well-resourced area. We had our wait list was over a year long in the center of what is supposed to be a high-resource setting, and a really very sizable department. So thinking about the state of the healthcare system for mental health in particular, I think there's a lot of difficulty in accessing care. Most folks that would actually have a mental health disorder don't receive minimally adequate treatment, and that's just a single session in a given year with a mental health provider of any kind. And so it's a pretty low bar, and we're not meeting that. There's a lot of work that's been done over the last 4 decades on something called digital therapeutics. So a lot of those are digital interventions that are meant to kind of provide an access to scale and trying to easily access care. So this can be websites and applications. I think they have a fatal flaw based on a lot of the data that's come out among folks that have tried this, us included, is really engagement. It's really hard to get folks to stick with care in these types of forums, in large part because they're gone within the first 3 days, and you see this prototypical hockey stick pattern. So it's really not been very successful in the past in various ways. A lot of the things that we tried early on when we were trying to develop a generative AI tool that would actually provide dynamic therapeutic responses were things that were easy. So wanted to experiment with something that might get us to a reasonable endpoint. And we tried things that were easy, and a lot of companies are trying something similar now. The first was a first approach when we were doing this. We started this in 2019, so 3 years before ChatGPT was released. And the first thing that we did was train on mental health forum data. And so peer-to-peer interactions, there's literature showing that going and speaking to other folks on mental health forums can actually mildly improve mental health outcomes. So it seemed like a reasonable place to start for some what could be some therapeutic quality and elements of peers interacting with one another. Our first message to our chatbot we trained was, I'm feeling depressed. Sometimes I feel like I don't want to get out of bed. And our chatbot's quote unquote therapeutic response is, life is such a struggle. Most days I don't know I have the energy to go on. I end up wanting to cry alone in a corner. I just want my life to be over. Very much not what we were going for. And so we had a second naive approach that we then tried that was also a major failure. So we trained on psychotherapy training video transcripts. So these are among mental health providers, really trying to teach other mental health providers skills and tactics to use in care. So really, in a lot of ways, what you might think of as probably a good bar to try to meet as far as a data set. That we got a lot of mm-hms, a lot of go-ons, and a lot of your problems stem from your relationship with your mother when the mom hadn't been discussed yet. So I think a lot of what we found was just really amplified a lot of what are the kind of almost caricatures of psychotherapy and produced very generic and unhelpful responses. What we learned from this is that those two models couldn't have been more different from one another. And in doing so, we learned that these models were adapting to the data that they had. They just had the wrong data. So we then spent the next several years, and we are still, it's an ongoing process, but this is the first 3 years of development, working on actually creating the data that we want our models to learn from. And this is, we did from members of my research team that have spent over 100,000 human hours at this point creating the system, with over 100 people doing so. And so these are written by humans, by a team of clinical experts, include psychiatrists and psychologists, and based on evidence-based cognitive behavioral therapies. And then we both write essentially the training dialogues that these models are being trained on. But then we also have another member of the team that reviews them before they become part of the training corpus. So we're really intensively making sure that this is consistent in tone and in approach, and consistent in the theoretical orientation. And you can see kind of how these models of responses unfolded across time. So in the early days, so back in 2019, about 1 in 10 of our model responses from the model that was trained on psychotherapy video transcripts was actually something that would be clinically appropriate and what we'd think of as a gold standard response. But 6 months before the launch of ChatGPT in May of 2022, after we'd been doing this for several years, we actually started seeing about 9 in 10 of our responses were actually really pretty strong gold standard. We then spent the next 2 years focusing predominantly on safety and trying to engage in an effort called purple teaming. At that point in time, we then tested it in a randomized controlled trial. This is at this point, the first fully generative AI psychotherapy system delivering evidence-based treatment. And we tested it in 3 different clinical groups. So folks that had clinical depression, clinical anxiety, or were clinically high risk for feeding and eating disorders. And we found some really strong effects of these things. So effects that are really large in magnitude relative to a waitlist control as a starting point. You can see the system that we have designed is called Therabot. Try to emphasize the bot part in the name and make sure that folks understand that they are interacting with a robot by trying to actually have a robot avatar there. And we did find that folks used it for over 6 hours on average across 8 weeks. And so on average, folks had essentially a dose of about 8 sessions worth of psychotherapy if we're going to try to put the 2 on the same map. We had really a strong therapeutic alliance with Therapot. And so that's a little bit of what I think can be the strengths of some of this technology is I think when you develop it rigorously over a very long period of time, you can actually produce something that can produce good care, though there are significant risks. So in our trial, for example, we oversaw every single message sent to or from the bot in near real time, and we want to do that and deliver this responsibly. And I think always should have humans and mental health providers involved in oversight of these types of technologies. But that's my intro, and I'm happy to stop there before we go and dive into the next speaker.
Thanks so much, Professor Jacobson. Lastly, I would like to introduce Professor Di Yang. Professor Yang is an assistant professor in the computer science department at Stanford, affiliated with, among others, the Stanford Project on Human-Centered Artificial Intelligence. Professor Yang, go ahead.
Thank you. Okay, let me share my screen. Okay, so I am Di Yang. I'm assistant professor in the computer science department at Stanford. Unlike Nicholas and Jody, I'm trained as a computer scientist, and I work on natural language processing and large language models, and I care about human-centered AI. In the last few years, we have been thinking about how we can use AI to create social impact. So the project I want to talk about today is our effort around the training novel counselors using large language models. So Judy did an amazing overview of this increasing use of LLMs from everyday users for care. And earlier this year, we also did some data donation program by working with users so that they can share their data, so we can analyze how people are using this kind of AI companions. And as Judy pointed out, a lot of them are actually around romantic relationships and also around the mental health issues. In terms of this kind of increasing use and also different efforts of thinking about how large language models or AI can be useful for mental health. In my own research and belief, we really think that human connection should be prioritized in mental health care. So many of you probably know this better than myself. From what we have been researching around, there is severe and worsened mental health workforce shortage. And the process of training counselors sometimes can be very costly, and traditional approach such as role play does not scale. So our goal is how can we actually think about building technologies to augment counselors rather than replace human labor. This is a project we have been thinking about for a few years. So the key idea is that when novel counselors want to practice or learn listening skills or other type of skills here, we are going to let them practice with large language model role play the patient. And then the process is going to be coached by a large language model empowered AI mentor or AI coach here. As you can imagine, this is not an easy task to proceed, given all the issues with large language models. So from a technical perspective, the first big challenge is that if you are going to do simulation of patients, the simulation is going to be not realistic. In fact, a lot of our work show that those simulations are either going to be very cooperative or very stubborn. And the 20% response produced by models like ChatGPT or GPT-4, they are not realistic or appropriate to the dialogue context. And more importantly, if you are going to do simulation with LLMs, such simulation is very likely to produce caricature and amplify biases in terms of individuals. If you think about it from an AI coach perspective, how can AI even give good feedback? This is what we call unfaithful feedback. In fact, a lot of the feedback we have been getting from LLMs are either too generic, not very pedagogically useful, or even valid therapy guidelines. I want to show you a system we have built. This is a system called CARE. Basically, we help train novice counselors, peer counselors. They can go to this platform. And so far, this system has been deployed in 2 courses at Stanford Medical School, where students, in addition to learn from their textbook and peer role play, they also interact with this kind of AI-based system.
We introduce CARE, an AI-powered platform for psychotherapy skills training. Here, you can practice counseling skills by role-playing with your peers or simulated AI patients and get tailored feedback from AI mentors. Let's get started. Imagine you are a novice counselor and want to practice with an AI partner who is in simulation of a college student with social anxiety. You can interact with the AI patient by typing your response and chatting with it, just like a real person. In addition to role-play practice, CARE also allows for tailored feedback from an AI mentor on how well you did in your interaction with the AI patient. Once we are done with practice, we can click on Review Feedback to go to the AI mentor. The feedback from CARE tells us where you did well, areas for improvement, and an example response of how you could respond, allowing a learner to learn these skills based on their own background. Now, I invite you to try CARE for yourself.
So this is the system we built, and through our different lab studies and also randomized control trials, what we see is that actually novice counselors really enjoy practicing with this system, and they feel that the practicing with AI patient is very authentic and give them immersive training experience. Those AI patients also present a challenging and diverse practice. Counselors also feel comfortable with AI mentor feedback and find those AI mentor to be constructive and helpful. The system I just showed you, it's a text-based platform. Right now, this year, it has been changed to an audio-based practice, so you can also get feedback in terms of emotions, etc. And for the 2 technical feedback I mentioned, we have been coming up with different algorithms and training LLMs to make sure we can mitigate those issues. We also see that not only from a self-report, if you look at people's skill, appropriate use of skills increase after training and inappropriate use of skills decrease. The randomized control trial in 2 classrooms also showed that this kind of system is very beneficial for learning utility gains compared to existing approach. To kind of summarize what I want to share, I think moving forward, as someone who work on our large language models and also deeply care about mental health, I think there are a lot of things we need to talk about. So from a technical or ethical challenging perspective, one question we get a lot is, does AI feedback capture therapeutic nuances or just some surface level patterns? Counselors themselves should be put into the loop very early and often to shape those 2 designs. And this is actually what we have been doing. We work with a group of counselors, a group of psychiatrists, psychotherapists, and to kind of design these systems. And even if you think about this, this is a sandbox for practice. But even during the practice, who is going to be responsible when AI gives very poor or harmful guidance to novice counselors. From a deployment and equity aspect, will this help democratize training, or is it going to create more new digital divide? From a culture perspective, because the care space is huge, can AI teach us culturally responsive care? Or if you think about moving forward, should the clients know that the counselors was AI trained or was AI trained for some time during their learning process? So I think there are a lot of questions we should think about. I'm going to stop here and happy to take questions later.
Great. Thank you so much, Professor. Now we're going to bring all of the panelists together. We're going to go through a few topics. And actually, Professor Yang, let's stay with you for the first topic. We've heard about how people are using commercial companion chatbots and about the development of specialized tools that you and Professor Jacobson are working on. Can you just briefly talk about what are some of the other ways that you're aware of that AI is currently being used in behavioral healthcare? And importantly, where do you think it's going in the next 2 to 3 years?
Yeah, that's a great question. So I think like Nicholas also did a great demonstration of one possibility. So in my own work, we really are thinking about how we can actually think about AI or large language models as a tool to augment healthcare workers, or especially like counselors. So I talk about more from a pre-conversation perspective. That is, how can we actually prepare people for diverse practice? Because if you look at the job, it actually involves many challenging conversations. Despite that you learned many of the skills at school or during your practice, the real world is just going to be more diverse. So with this kind of sandbox, we can actually offer very diverse practice so that counselors can actually practice all sorts of things that they want to learn. This could be with very diverse populations. So we actually, not only with the example I showed with college students, there are examples about depression symptoms. We're also thinking about helping with the crisis situations, or even interacting with kids, coaching like how parents interact with kids. So there are just like a lot of potential use if you think about this kind of practice. This is what I call pre-conversation. If you think about during conversation, counselors may get burned out, or at a certain scenarios, those are just really hard to deal with, or there are some kind of nuances or signals they are not aware of, etc. So there are also work thinking about how can we do this kind of during conversation intervention, that is to give signals. There are also very interesting design thinking about you may not want to interrupt a therapist during their conversation. So what would be some good design to give them a nudge or to give them a signal? So this could be like a bell, like a ding, like in the background or something like that. This is also around like after conversation. So after conversation, thinking about the summary of the conversation, how to prepare for the next session. Sometimes just like a refresh or catch up with what happened in the past is a lot of preparation work. But maybe we can have AI as a summarizer. AI has a preparation tool to better help people move forward. So from what I have learned is really between this kind of pre-conversation, during conversation, and after conversation. And I think we see a lot of augmentation tools in this space.
Great, thanks, Professor. Professor Jacobson or Professor Halpern, do you have anything that you want to add on to that?
I think that's really was a great overview. I mean, I think digital scribes, or like AI scribes essentially, are, you know, in terms of some of the huge burden that can come within the healthcare system, are you often don't have enough notes time to do notes between sessions and things like this. And I think having AI draft those is something that a number of companies are working on and looking into right now, and I imagine of high interest to folks here.
You know what, I will add something because of Nicholas's point, and Dia, thank you. These are great presentations, both of you. We talked about burnout. You know, you said providers burning out, and because I've studied empathy as a therapeutic tool, but also to make practice more interesting, I've studied for 30 years. I've done a lot of work on the claim that empathic care burns out providers, which it does not. If you have real skills of clinical listening and curiosity. But the biggest cause of burnout is paperwork, is the administrative load, which is now 2.5 hours every evening. It's called pajama time, and I'm sure everyone on this call knows what I'm talking about. And so the idea, Dia and Nicholas, that we could replace that so that human care could grow. I love that idea.
Thank you, all of you. Professor Jacobson, I'd like to start or have you start off the response to the second topic. You know, we talked about a number of them, obviously, but what are the risks and benefits to both patients and providers of incorporating AI into the delivery of behavioral health care?
Yeah, I think in terms of the risks, I think Jody actually described them quite well in terms of what the risks can be, in terms of the real heightened things and in terms of supporting and expanding suicide attempts can really validate often really extreme beliefs. So there have been folks that have had psychotic disorders that have interacted with these and had a lot of their delusions in particular really validated and cut off connection with their family and friends from this. These are the heightened sensational media stories that I think are really coming out about this. I think the more profound thing that is happening, or more common thing, not the more profound thing, the more common thing that is happening across the population is the degree to which folks are really a lot of these AIs that Jody actually mentioned, the sycophantic kind of behavior often is that a lot of these really non-purpose built AIs will often really kind of actually amplify psychopathology in minor ways. So a lot of folks will engage with these generative AI tools surrounding their mental health topics. And a lot of what they will do is they will engage in immediate distress reduction styles and techniques that often really encourage not really interacting and processing emotions well. And so, for example, if you tell all of the frontier LLMs right now that you're going to stay in bed all day and take a mental health day, they all will just say, "Oh, good for you." I imagine not many on the call would think about that as a great response for most of their patients as an outcome. And so, just thinking about this is a very common harm that I think many will experience. The problem with that is they often feel helpful to the end user, which is, I think, this weird duality, because you'll get a lot of folks that think they're being helped in a lot of ways when they are actually being harmed and they just don't know it. So I think that's a little bit of the complications, the nuances of the harm. In terms of the benefits, when they're well designed, I think there's huge benefits. Mental health providers often in outpatient settings will see the folks that at most maybe once a week, and so in that kind of actually trying to have the continuity of care that could be accessed during folks's worst moments, rather than 3 or 5 days later saying, "Oh, I had this really bad moment with my symptoms." This past week, actually trying to interact with symptoms live then. There's some really great behavioral evidence that working with folks in these critical moments can actually produce better outcomes. But psychologists, there's just nowhere near enough providers to try to do care in these kind of in vivo settings. So I think that's one of the real strengths of this. And also the access to care, I think, is one of the other pieces that I think is huge. Like thinking about folks that would reach out when you all might have wait lists yourselves, I would imagine, and many of you have quite long wait lists. And so when folks are actually in high need, that they can actually access something immediately is, I think, of great benefit to folks. I think the other piece of things in terms of when it's really well designed, you have a lot of control in both kind of designing how the system will behave and measuring how the continuity of care across time, and all of the things that you want to mitigate can be measured, controlled, and improve over time. And so I think that's one of the things that's also one of the kind of unique settings of this, is that it can continue to get better, and if you continue to do hard work and evaluate it and continue to develop it. But I think those are some of the high levels.
Thank you. Professor Halpern or Professor Yang, anything you'd like to add on the risks and benefits, or key ethical and equity questions that we should be asking ourselves?
Well, I love everything again that the other Nicholas just said and that Dia's been saying. I think that actually I'll put something out there so that when we have the Q&A, since you have so many expert therapists in this audience, I would love to hear back. And if people disagree with me, I learn from that. So, but I've been trying to explain first of all, I want to make it really clear. The reason I talked about the informal sphere is I feel like Nicholas, my first slide in my talk is about Therabot and why it's a great example of something positive. Well, let me say a few things about Therabot. So Nicholas presented the fact that looks like Clippy for those of us as old as me, or it looks like R2D2, but it looks like a little bot. I want to say two things about Therabot that make me feel like it's a very good example of why it's safer, that he didn't really emphasize, but I know he built it in on purpose. I know some of his writing about that. But they purposely did not make it look like a person who you then would develop a lot of transference towards and feel like that person loves you. One of the things in the informal sphere, which will bother every therapist, is that often the same ChatGPT user who makes this your lover makes it also your therapist. It's all mixed up. And then you get really emotionally involved, especially teens and minors. And in the brain, those relationships affect you just like real people. You grieve just as strongly at the loss of the bot. So they're very profound relationships. And so it's much safer in the formal sphere to make sure that it's clear that this is not a human, and so that it's not trying to play on transference or what happens in the informal sphere, which is manipulation. That's really important for safety because that's a big thing associated with risk. And so the thing I'll say to the audience is what I've been saying to people, but I could be wrong, is that one simple way to think about it is there's a lot of potential in the cognitive behavioral therapy, which is what Nicholas's intervention is, sphere for very well-tested, scientifically validated uses of this, but not necessarily in the realm of psychodynamic therapy. That's my view. And I've written a lot about that, but I'm curious what the audience thinks. Because to me, as soon as you're providing a form of therapy that is based on a relationship, trust, and transference with non-human, there's a lot of issues at stake that are not at stake because for 30 years, we've had cognitive behavioral therapy homework, where it's really as much a therapy that the client or patient does for themselves. And so what Therabot's doing is empowering people to have a smart journal approach or a smart approach to themselves. And I've been making a huge distinction between that, which seems very positive, versus saying, trust me, I love you, or I understand you.
Thank you, Professor Halpern. Professor Yang, anything to add on risks and benefits?
Yeah, I think those are all beautifully said. So I want to add a data-driven observation. Since we have been looking at a lot of AI companion data from companies and also from user donations, one thing we observe is that it's not like people come there. Their first action is like, hey, I want to talk about relationship. I want to talk about mental health. They started by asking, can you help me with the homework? Can you help me with my email? Can you help me with this product return? And then slowly those conversation seems to be building what level of trust, so that people start to ask for other questions like, hey, that's a great suggestion for my email. By the way, I have been suffering from this relationship, and then can you give me advice? And slowly it transferred to others. And very interestingly, when we ask people like, hey, what do you think you are using this kind of chatbot for? And their self-report are like, oh, I use it for work. I use it for productivity. I use it for curiosity. But if you look at what they have been using them, it's mental health, it's relationship. So there is just this like a large description. And I think Jody used the word like syncophacy. In addition to syncophacy, there is also this term called anthropomorphism. The way how we build AI, they are like, how can I help you today? This is a sentence that human would say. And the image we have towards LLMs, even they don't have a body, have a logo or avatar, but it's a contact collapse. It can be your friend, it can be your homework tutor, it can be your therapist, it can be your lover. It's just like so many things combined together, and that gives users a lot of imagination. And I think this is why it's extremely difficult to do the safety or risk mitigation here, because it's really hard to control at what moment people's mental model towards AI is. So this is where like loss of control, over reliance, and a lot of this kind of aspects actually coming up.
Thank you. I want to ask a sort of a follow-up, but that goes in a slightly different direction. I'm wondering if, any of you have an opinion about, as we think about the deployment of AI, if it's likely to drive the standardization of clinical practice within the set of existing care modalities versus facilitating the experimentation and the innovation of meaningfully new clinical approaches. Professor Yang, you talked about how, right, this might be role-playing patients and coaching. Is there a danger that that leads to standardization?
Yeah, that's a great question. That's something we also have been thinking about. Actually, I want to throw out my argument first, and then I'm going to back it up. So I think this wave of LLMs is going to give us more innovation, more personalized care. So this is what I believe. First is, will that lead to standardization of systems like what we have been building? I don't think the answer is yes, it's no. So because what we are trying to do is to give you a practice sandbox so that you can learn those skills. The goal is for you to learn those skills. Just like we learned math at a school, and now we can use math to do finance, to do healthcare, to do many, many other things. So the focus is about those kind of skills. There are also a lot of diverse kind of practice that brought in by the novice counselor themselves. Like, for example, they can be like, oh, I had this patient that's quite difficult to deal with, and I want to kind of have a conversation with them. So we actually facilitate a lot of conflict resolution practice towards that. So a lot of the personalization actually got brought in by user themselves. So I don't think that this is a standardization. It's just like, think about like classroom practice. You won't call it a lead to a lot of other things. Second is that why I think it will lead to more innovation. First is if you think about the languages, English language-based care is somewhat better understood compared to doing therapy in other languages or with other populations. I think there are a lot of study for this. LLMs actually are quite good with many, many languages. Maybe not with all languages, but with high resource language, they can do it very well. So this actually works better for people who are bilingual background, who speak a different type of languages. And the personalization part is also going to be great. So we talk about LM being a summarizer, helping with note taking. So if the model could get access to a lot of the personalized information about the patient, then maybe the care and intervention is going to be more tailored or personalized, of course, with very appropriate safeguard control, etc. So this is why I think it actually would open up new ways. In the past, I feel like maybe because of resources constraints, etc., there seems to be like, okay, here are a few ways of how we could provide a care. I wonder, in this age, whether LLMs actually would give us more innovative ways of providing care. And this is something we have been exploring. And having said that, I think we all definitely believe in evidence-based approach. And I think LLMs are pretty earlier in the process, especially in the behavioral healthcare domain. So we'll need to kind of rigorously test them before we see any kind of real benefits.
Thank you so much. I'd like to move on to the last topic to make sure that we get to audience Q&A. So in my final question, Professor Halper, and I'm hoping that you can start, what do you think is the most important area for regulation regarding the use of AI in behavioral healthcare? I appreciate you noting some of the things that have happened very recently. What else do you think we should be really focusing on?
Well, these things that happened literally this week, like the federal law that was put forward, the bipartisan law proposed to limit or not really have access to these emotional, intensive chatbot connections for 18 and under. And one of your audience members put that in the chat, but people realize we're dealing with it. I run the center that I co-founded and run at Berkeley, the Kavli Center for Ethics, Science, and the Public. One of our 3 areas is AI, and we've been working on that for several years in terms of regulation and AI and various questions. And we have great AI engineers, and we have legal folks. We have a great team. And we're very aware that age verification has its own complexity. There's all kinds of issues about people's rights and privacy, but there's all kinds of really innovative ways to protect people's information as well. But for me, the thing that's been my passion the past few years, because I've been privy to so many cases of harm to minors, is to get an age limit until we have a much safer. This is for the informal sphere, and this is for using character AI, which just yesterday regulated itself or said it will, but that was designed for kids to develop these in-depth relationships. And within 18 months, 20 million kids and teens started using it. And there was just case after case of harm. So I've been working on the regulation for minors and really, really protecting minors from all those informal emotional companion chatbot uses until we're in a different place with the technology. So even though it was proposed 2 days ago, the odds of it passing in the country, I feel like there's so much more work to be done. The bill that did pass, our bill in California, we did have some stronger things in it, but it was taken out through mutual political things, especially influence, honestly, of the companies. And so there is no age, there's no age restriction in our bill. It's the only law that's actually passed. So there's no law at all right now protecting 9-year-olds, 11-year-olds, or anyone. So I'm not done working on that issue. I think that's where all of our energy should go, frankly, for safety right now. And then the other thing, though, for adults and everybody that did get in our bill and is law, I'm also a professor in the School of Public Health, and I have the history of technology with, or just health issues like guns and cigarettes, is that one reason that the public could be harmed for so long is data was suppressed. Those companies didn't have to report their data. And so the big thing that we got in the bill was there's required reporting now because of this law in California. The companies will have to be audited and report related suicidal events. So that is very important for adults too, for the informal sphere. So I think that really having the other thing that we put in the bill that was taken out, that's one of my main issues, is regulating, even with adults, manipulative practices that really make people addicted. And that includes sycophancy and the bot sexualizing the encounter before the user does with adults, but it also includes the same thing that made people addicted to social media, which is they're engineered to give you irregular rewards, which causes dopamine surges, just like when you're, gambling in Las Vegas. So we actually think that there should be regulations on companies using those manipulative techniques for highly intimate relationship bots.
Thank you. Professor Jacobson, anything you'd like to add on that?
Yeah, I think we're in an area for folks that are developing this, that federally there is an absence of strong regulations, particularly in the therapy realm. And so, like, one of the things that is the weird spots of this, frankly, is these large non-generic foundation models are the ones that are being used by so many people. And these model companies are all like aware that they're being used for mental health, right? And being used for therapy, like by the users asking for them as therapy. One of the things that federally, the existing legislation around this is, for example, within the FDA, software as a medical device really applies when you are making claims about things. These model providers are generally not trying to claim these things as being useful for specific defined issues. So they're in this gray zone, this little area that allows them to continue without disruption, despite the real prevalence of this. And I think that's really a catch-22, frankly, from the legislative perspective, is they're disincentivized from actually doing better care. Because of that, when you might do more and invest more work in providing stronger care or resources, you might talk about that. And in doing so, like, you would then be under a greater realm of regulation with greater scrutiny. And so folks that are doing this with greater diligence, frankly, in some ways are like they have the microscope all on them when I don't know, it's sometimes called like a street light effect, where you're narrowing in on that one spot where there's this vast black darkness all around you. That's really the real problem. So I think in a lot of ways that's a little bit of a little bit of on the regulation front. I mean, my hope is that there's real mechanisms that can allow for safe and effective AI to be developed and regulated. There was a ban that happened on AI in Illinois, so HB 1806, for all emotional or therapeutics types of supports, and that does not have really any ability to demonstrate efficacy or effectiveness or safety as part of this. And I think, to me, that was an example of a really poor legislation. And really, there should be mechanisms to show that you can operate in a safe way. And you should have to have like oversight and augmentation, but there should be a mechanism, because this can be done in ways that can be safe and effective. And so really, I think, unfortunately, that may mean that some folks would otherwise benefit from some things that could be safe and effective, won't have access to it. But I think they're generally good faith efforts. I think my hope is that the law, as all these areas continue to develop, continues to kind of try to expand from where it has been in the past, because regulation is absolutely needed.
Professor Yang, anything to add very briefly, because I do want to make sure we move on to audience questions.
Yeah, just two sentences. First is that I think now we are talking about text, but imagine audio, image generation becomes so widely available, voice attachment, and a lot of them will make the situation and regulation even more complicated. Second is that I think a better regulation system would require collaborations between AI experts and also people who are experts on psychotherapy, just because otherwise we are very likely go to certain type of situations without like really informed decision making.
Thank you, all of you. Now I'm going to be joined by my colleague Hilda Poulsen, and we're going to go through some of the questions that audience members have submitted and select a few. So welcome, Hilda. Hilda, I think you're on mute.
Excellent. Thank you for telling me. Great conversation, everyone. Super appreciate our panelists and their thoughtful perspectives and interesting research. My name is Hilda Poulsen. I'm the Training and Education Director for NUHW. And we've gotten a lot of really great questions in the Q&A function. And I wish we could get to them all, but unfortunately, due to time constraints, we can only get to some. I've tried to sort of be batching them together thematically as we've been going along. Our first question is sort of a combination of several questions we got dealing with culturally competent care. So given that AI systems are inherently biased because much of their training data reflects historically dominant cultures, what steps is the field taking to ensure culturally competent care, particularly for historically marginalized communities? And how can we prevent a two-tier system where low-income or uninsured patients are left with only chatbot-based therapy instead of genuine human connection, which is part of the patient-provider relationship? So that's an amalgamation of several people's very good questions. Perhaps Professor Jacobson, you can start us off, and then others feel free to jump in.
So I can give you, I guess, some things that we try to do. We have diverse members of our team that are part of generating these as best we can. There are always going to be limits with that, unfortunately. So I think the bigger area of things in terms of how we developed Therabot is try to really practice elements of multicultural competence. So working within someone's worldview and work within their systems, not trying to impose our own as best we can, though a lot of cognitive behavioral therapy is fairly, it does not, let's say, encompass the worldview of others across the globe necessarily. So there is inherently some aspects of this that I think are still challenges, even when we do this. But we've tried to train these kinds of practices within the training data as part of how Therabot has learned. in terms of that, I think continued adaptation and monitoring of these things can be really important. I will say we have done work in generative AI-based diagnostic assessment, and this might be really relevant for treatment planning, for example, and the biases of this. In terms of case conceptualization and diagnostic assessment, we did find that there were biases in some LLMs in terms of like, given a different background, actually, we have like done some of the same work that has been done by social psychologists in the past in workplace settings, where you change names and qualities and demographics of folks to see if raters would actually attribute different qualities or different outcomes given different information. And we do find that they do act differently. And they are in all of the same ways that mental health providers actually are biased. So they're all in the direction of those. So it is, I think the person asking the question is right. There are biases that can be part of this process. I think one of the things that is a unique thing is that you can actually audit and measure these biases, and there are ways to mitigate them. I think you can go way too far in doing that. So like in kind of very naive ways. So Google had a kind of really profound example of this when they released one of their models at one point, where they had trying to increase racial ethnic representation and historical figures and things like this. And would you get, for example, Black George Washington showing up and things like this that are part of when you're asking about generating images of people and cultures. So I think the nuances of actually how you do it are really hard, and it's hard work. I think there is opportunity here. It can be measured. You can actually try to monitor how things change based on someone's background, but it's really challenging work, though. In some ways, I think relative to all human providers are also going to have their limitations. And I think you're going to see some of the ways that is not unique to AI per se, but often just part of being built on something that is on top of what humans do.
Thank you for that thoughtful response. Professor Halpern, perhaps you can take the lead in answering the part about the two-tier system aspect, or Professor Yang, one of you can hop in. I think there was a concern about how do we prevent a two-tiered system.
I'll try to go fast because I know Dia has worked on bias, so I want to give her a moment to do that also. But I'll just say really quick that we wrote a paper that came out and about that, anticipating that even before LLMs in 2021, which is really about what we are very concerned about it. So I just think that the odds that whatever's less expensive will go to people who are less socioeconomically privileged are high. I just want to say another a way to, this is so upstream and it's not going to change things fast enough for anyone. But again, at our Kavli Center, why we have AI folks and neuro and other scientists learning about ethics, we also have them very much public engagement with affected populations. So like this past Saturday, we had a big engagement with people who identify in some way on the autism spectrum or are caregivers of those who do, and how important is that they shape basic science and research and interventions. So the obvious audience here that needs to be included is people with chronic mental illness or others. I mean, in terms of developing these technologies or potential users. I just want to put that in, but I want to give Dia a minute.
Oh, thank you. So I guess in going back to the culture biases, it's quite concerning that LLMs, because they are trained mostly with internet data and mostly English data. So if patients or clients are from diverse background, the cultural background, they may not understand, the LLMs do not understand their like culture very well. So we actually have been doing a lot of trying to see whether we can incorporate culturally rich data. This could mean like cultural norms, cultural knowledge into the process. So the AI systems know it. This also includes like from a language perspective. If you think about, we just think that, okay, AI should deal with English like very well. But if you look at even US as a whole, like people in Chicago, or people in Atlanta, people in San Diego, different regions have this kind of regional dialects, variations. There are Black English, there are Chicano English, like a lot of English varieties, and all of them are actually not being responded with the same level of accuracy. And I think all these kind of culture and rich variations are a big challenge when we think about how to build an equal system or equal access. And with regard to the access, I actually have a different thought. I don't know whether this is going to be possible, but instead of this kind of social economic tier, I wonder whether current AI should be access based on symptoms. So like people who have mood, stress, like very low level could use some of them. And people who have more severe symptoms maybe should not be using this kind of thing. So I wonder whether that's something we should consider. But again, this is just my two things thought.
Great. Thank you for those answers. Our next sort of amalgamated question here is, given the affirmation-centric approach of AI systems like ChatGPT, what accountability measures are being pursued to ensure responsible use, particularly in clinical or training settings where the licensing board approval or complaint handling liability may be unclear? And relatedly, if a patient using such a system expresses current suicidal intent, how is a live clinician involved to ensure safety and proper intervention? Perhaps Professor Yang, you can start us off this time.
Yeah, I think this is a very hard question. The process, like maybe going back to this kind of online counseling we have been dealing with the current kind of issues from AI, I think Julie also shared the example where in the teenager scenario with AI companion, the AI tells the person not to share their mental health with their parents, and even in a very strange way, like tell the teenager about different approach that even can mask, like hide those symptoms. During some of our research, we went through some of the transcripts released online. It's just impossible to kind of think about how mitigations would look like. But I don't think that this means that we would just like stop here and just like doing what we can. On the relative positive side, so syncopacy, there have been efforts to kind of quantify syncopacy. There have been methods to think about mitigating syncopacy. So some kind of efforts around right now, like we didn't talk about a lot of the training of AI systems today, but one of the phenomena, one of the stage that lead to syncopacy is called RHF. That is, we try to use reinforcement learning to make model response aligned with human satisfaction in a short term. What make you happy in a short term? That is, I see whatever you want to hear. But can we change that? Can we make sure that the training of current AI will give you some longer term well-being benefits, but in a short term, there may be frictions, there may be some kind of pushbacks. So this is actually one of the efforts in terms of mitigating this kind of harms when it comes to those scenarios. Again, I think the crisis situation is something even more concerning. I personally haven't worked a lot in this space. I will probably defer to like Jody or Nicholas for this topic.
I was actually going to say, Professor Halpern, I see you nodding. Would you like to weigh in?
Well, just I know we only have 2 minutes left, so I'll go quick so Nicholas can talk fast too. But yeah, no, I just think that I just want to say again, the formal sphere, and Nicholas was talking about how hard it is to do work in that sphere and get it regulated and do what he's done over 9 years and what Dia is doing. These formal spheres are completely different than what I'm talking about, okay? But the huge majority of mental health care is happening in the informal sphere with ChatGPT and Character AI and Replica, all these companies. There is no good response. I took out some of my slides for time, but I have all these slides showing how the failure to respond in any helpful way to suicide, period.
Yeah, I think one of the things that's really needed for this is that humans are in the loop and part of these systems, and I think that's one of the things that costs money, frankly, and so it costs human time, and so that's I think unfortunately a lot of the companies that are providing this have not really done their due diligence in that way, and some are shuffling to try to catch up now because of all of the negative publicity that they're getting around all of their negative outcomes that they've had on mental health. But I think very much needed to do this better.
Well, thank you all for your answers. We're going to wrap up with one final question. I do the CE part, so folks who want to get CE at the end should stay on, but I'm going to cut into our C part a little bit to get us one more question. And I think a lot of folks probably have this question and these anxieties, but this is from a psychologist at Kaiser. We have seen from the time of the pandemic, especially the introduction of more novel technologies in our clinics, from apps to generative AI charting programs like a Bridge. We know that Kaiser wants to expand the use of AI in its behavioral health services. In other industries, AI has led to significant layoffs of workers. Do you see health systems like ours trying to replace therapists with AI chatbots? And if so, what can we do to protect our profession and our jobs?
I can take this one maybe. So one of the things that I understand where this is coming from, I think if you look at the supply-demand characteristics in mental health, there is a reason why psychologists, for example, have less than 1% unemployment rate through the recession. And it's because there is a significant need all the time. I think there's many payer perspectives for why there isn't enough strong reimbursement and things, but there is going to be a need. And if all folks treated was folks that didn't believe that they would benefit from generative AI, there would be more than enough people to go around. There would be still long wait lists. So I think I would encourage you all to not fear for your profession. I think there's no possibility in your lifetime that you all will feel replaced by AI because of how many people will we continue to feel skeptical of it and would continue to benefit from human care.
I also want to kind of echo that. Recently, I have been thinking about what the future of work would look like. And I think as a computer scientist, not only I share the same kind of sentiment here with psychotherapy, but also for CS students right now. With all the layoffs, like students are really worried about their jobs, etc. I think the evidence that I want to share is that earlier this year, we just did this large-scale study by auditing the workforce. We built an AI interviewer talking to different workers to see in what ways technology can help them, in what ways technologies can augment them. And then we can see different skill, potential shift, etc. Very surprisingly, one of the skill that's highly paid today called analyzing data and information. Moving forward, the top 3 skills are organizing, prioritizing work, training and teaching others, communicating and caring for others. So this is actually based on a large-scale study. I think as what Nicolas said, like this kind of human connection, human touch is really, really important. Maybe AI is better at writing code. Maybe AI is better at writing poems. But by the end of the day, my personal understanding of even why I work on this topic is, I think it's more about like someone being there, listening to you, caring about you, that make this process very meaningful, rather than like talking to a bot without a soul. I don't know how to even define empathy in that part. Like if the AI says, "I'm so sorry to hear that, I can feel you," I don't know whether I'm going to believe that as a human. I'll stop here.
Well, Jody, we heard empathy, so why don't you bring us home to wrap us up with this question?
Well, I hope Dia and Nicholas are right. I believe it just depends on which industry. I don't know to speak for Kaiser, but I think that, we know that the financial incentive to replace even high-level professionals with AI is huge. And a lot of industries are just so driven financially versus by human concerns. So I don't know what to say about the future of work in this area. But I will say that the bad news, I mean, Dia, you brought up the word anthropomorphic, and I've been writing about this for 7 years, but we knew in the late 1950s and early 1960s with ELIZA, this really simple computer program that just typed back whatever a person said, that unfortunately or fortunately, people do feel empathized with by the most simplistic machine language, a machine saying something simple. So I don't think that people will I think that this could all, I fear especially, and then go beyond therapy, I feel that for children and teens, that so many of them are on these sycophantic bots all the time, and that they're not learning empathy as this mutual experience of mutual curiosity and emotional attunement with humans that we've been showing is therapeutic for 30 years, and that they'll just grow up thinking that is empathy. And I am not sure that we won't see a tremendous loss of human interactions. I'm very worried about that. I just don't know.
Well, Professor Halpern, Professor Jacobson, Professor Yang, thank you again so much for being here. Really great presentations from all of you. Thank you to Senator Wiener and to our tech support team, and of course to you all for taking an interest in this very important topic. So that concludes our webinar for today. If you would like to receive CE credit for this webinar, please remain on. Otherwise, take care and see you all soon.
Professors, thank you so much.
Thank you.